Yeah, but my cover letter is available, but
I didn't do it for me.
I need to,
Yeah.
I think it's just online for.
That
So
coffee's horrible.
how many,
Yeah. It's not intended to taste good.
how many
That doesn't smell
jobs
horrible.
are, how did you get on with the job search?
There's a lot of jobs out there. I do have a question. Some of them I saw, preferred 1 to 3 years experience, and I thought that was odd because I would think you'd say prefer 3+ years or 1+ year, but why would you put 1 to 3? Pay? That's what I was thinking. It was an
They're only
entry.
willing to
Just-
pay so much.
I guess just to let you know it was entry
Yeah.
level.
The other thing is, there are some that say entry levels accepted, yeah. That could be something to do with HR. Sometimes HR are in a world of their own. And since HR actually make up the one ads, as it were, that's usually what happens, it's usually the HR. And the chief therapist or the manager, or whoever is sending the information may say, oh, I want somebody with a year's experience, so what
I mean, if they
HR
say
sometimes
prefer,
does-
if that's not a requirement, they say prefer someone with 1 to 3, is that something you could apply to
Sure.
as a new grad?
Sure, yeah, because all it's saying is preferred. If it was saying something like must have 2 years of experience, then they're not gonna
Required.
look at a resume that doesn't have that. But if they say preferred, then yeah. So, you found lots of jobs?
Not very many in Florida.
I already have a job, like, notification set up for places that I would go. So I get them, like, daily.
Yeah, but that's fine, I mean, just out of interest, can you tell me which areas you were looking at?
New York,
Okay, and,
Long Island,
so you're looking at the northeast?
yes. Because I'm from New York.
Okay, well, I was gonna ask you why,
Yeah.
but yeah, well, that's fine.
Oh, my mom is still
And I
there.
presume your husband's going with you?
Maybe.
He might not.
I can't talk.
If
I
I get pregnant again, we'll be divorced. But no, I think he's just gonna follow me wherever I go, and then he'll get his job.
Yeah.
But I was looking there. I was looking in Texas. I'm not sure that I really want to go to Texas though. I was also looking at, but they get paid pretty well in.
Texas?
Yeah, I was
Yeah,
looking at.
they do, yeah, they do.
Cost of living is low.
The
Yeah.
majority of places in Texas that would be looking for people would be in and around Houston or in and
That's where
around
he's from.
Dallas.
That's where he's from. He's from
Yeah.
Houston, so
Yeah.
I want to be like by one of our families.
Houston, I don't like Houston, it's too big. It really is, it's enormous.
Mhm.
And it's not enormous like New York's enormous, it's spread out enormous.
Yeah.
And there's something like,
Oh,
what is it,
Jacksonville is.
8 million or something in Houston at the moment, so it's a big place.
Mhm.
And of course, you've got Dallas, Fort Worth, which is not quite as big, but almost. Anybody else?
I wanna work at the site I'm at right now. I love it. And they're looking for people. I'm like, just like wait for me.
Well, oh, and I got an email from
Huh?
Fred.
Yeah.
They just bring it up.
The guy in Sanford. He's looking forward to having me down there. So that's tomorrow, right?
Yeah.
No problems with
Okay.
your jab, no problems with your second? No, good.
Did anybody else react from the second dose?
Yeah.
Have a weird reaction?
I had a small one.
I just like my head was really weird for a minute.
Yeah, yeah, that's normal.
And then I had like bubble guts for like 3 days. I didn't
Yeah,
like use the bathroom ever, but like it's just my stomach was bubbling constantly, and I thought I was,
yeah.
you know. Not
Yeah, there's
really,
a lot of people having weird effects.
But I didn't. The first
Is
shot
that
made me so
everybody
much more sore.
vaccinated now? You haven't, you've got, didn't you say the first one done? No, okay. So everybody except yourself? Okay, that's pretty good. Are you thinking about it?
I'm thinking about it. As soon as they say it's required, I'll get it done, but
Well, you
Have my
see,
reasons.
that's fine, you have the reasons. The thing about saying it needs to be required is that it's actually not legal at this point in time to say that you have to have
Probably won't be for a while.
a vaccination for schools or hospitals or something like that. But if it's a standalone centre, public or privately owned, or a privately owned hospital, then they can say, yeah, we need it done. The reason behind that is we're still covered by the emergency
Get into there, but
acceptance of the vaccination. Once it becomes permanent, like the flu is, then people can say, you must have it. And most hospitals will say, you must get a flu shot. Otherwise, one week, some of them say you can't work. The other one is that, like the one I worked in California, is that somebody who says they don't want the shot, and this of course in California, which is weird anyway, you have to wear a mask for 6 months out of the year.
I've heard of that in other places too,
Yeah.
outside of California.
They're weird. But, anyway. So anybody else get an idea of where they wanna work by looking at the situations vacant as they were?
I'd work at Flagler.
Pardon?
I said I would work at Flagler. I just don't think that they need anybody.
On social media, on some of the websites, the groups that they have for radiation therapy, there's one of them on that's like worldwide radiation therapy group.
Right.
They're constantly people getting on there saying, we need people at this location, we need people
Yeah.
at this. Amarillo, I kept seeing that one popping up.
Yeah.
I'm not moving to fucking
Yeah.
Amarillo.
Even in Alaska, there was one.
Well, yeah.
Basically New Mexico.
That would be cool
this
to
is-
travel
these are
to
the-
go somewhere,
the
you know.
Places
But I
where
mean,
You go to Amarillo.
they're
And
not,
tell me how it fucking sounds. It smells like
fashionable,
shit.
as it were.
Well, they're talking about compensating you for travel
Oh,
and
yeah.
moving all the way up to Alaska.
Yeah, oh yeah. Well, to get someone to work in Alaska, they have to do that.
Mhm.
Even when, about a couple of years ago, when nobody was giving resettlement allowances, Alaska were, because you can't get
I
people
do
to work in
Alaska
Alaska if
in
you
the
don't
military.
pay them to do.
That's it, man.
I
I'm
would
getting
do it,
the
but
fuck
it-
out of there. I'm visiting there.
That's the problem.
I know.
And I know I'm gonna get paid.
I looked at the ones in Alaska. I'd like to do Alaska for 2
Yeah,
years. I
Yeah,
think that'd be cool.
that
Yeah,
would be cool.
travel,
I think
really,
so
I
too.
think that would be fun.
you,
I would do it if somebody went with
for
me.
Alaska, you have to be willing, of course, the weather
The only thing is like if Trey
doesn't
has to be a
help
police
no
officer,
more,
so like
especially in
I
Fairbanks.
can't be like, hey, let's go here for 2 years. Let's go there for 2 years. You're gonna be like,
of time.
I'm never gonna be. Yeah.
And then you have
Get anywhere.
6
Yeah,
months out
I'm
of the
never
year
gonna be
where you
able
don't
to
see the
get up
sun.
and rank in the
Mhm.
That is
you know?
the other drawback.
That might be a problem for me.
Pardon?
Look at this
But
one,
that
it's
might be a
like wet.
problem for me.
Yeah,
Ew, this is
exactly. So it's a case of you either love it or you hate it in somewhere like Alaska. But even in the north, I mean, when I worked in Calgary,
It's nice that
in the
you can shoot
winter,
this and you can have
it didn't
food
get
for fucking
light till
the rest
about
of your
9
life.
o'clock in the morning, and it was dark by 34
You're
copies.
gonna have to dig in.
No.
It's a short day.
Shortly, very shortly.
My
That's
sister has a
another
house in
result.
Alaska.
Huh?
My sister has a house
Okay,
in Alaska.
so, technical writing. What's the difference between technical writing and, I know nobody writes anymore. Everybody texts, everybody emails. What's the difference between writing a letter to somebody and technical writing?
Writing a letter to somebody is more personal, technical is more formatted.
Informational.
More what?
Formatted.
Formatted, also formal, right?
Is it like more informational?
Informational, yeah. So let's see, this is not
Like TOs?
necessarily
You guys use TOs?
healthcare writing, but it's
You don't know what
this
they're
is
ordered?
for, believe it or not, for schools, so bear with me here. So, identify writing, okay, what technical
Pretty much
writing
everything.
is, what technical writing looks like in the content areas, how to integrate technical writing into your content area, and how to assess technical writing. Okay, so what kind of technical, having had a little bit of time in the department, what do you think we do as far as technical writing that goes? What do you think we do
Patient charging.
with technical writing? Yeah, patient charging. So that would be patient receiving treatment at such and such a centigrade of the dose, is complaining of da 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 da, right? You sign it, you date it, and it goes into the chart. Is that technical writing?
Sure.
Is it? Yeah, kind of. What happens if you go to a conference and the chief therapist says, yeah, we're sending you to the ASRT Radiation Therapy Conference and it's in Chicago this year. You will give a presentation when you get back to your staff members, to your fellow staff members and the students. Is that technical writing? Would that count as technical writing? Yeah. So how would you do that? How would you give a presentation? Stand up there and talk?
PowerPoint.
PowerPoint? With pictures?
Mm-hmm.
What else could you put in the PowerPoint? I mean, apart from the pictures.
Words.
Data.
Data,
Statistics.
statistics. The problem you have with statistics is you have to be completely aware of what the statistics are saying and how to explain those statistics. So if you just copy them off of, sometimes when they're doing presentations at the conferences, they will send you, if you ask them nicely, they'll send you their presentations in the email. However, please don't show that presentation as your own. What's that called?
Plagiarism.
Yeah, and that is frowned upon. Especially if someone who's already been there and seen the same presentation and you think, oh, that's not good. Yeah, so you don't want to do that. So this is the ideal technical writing is you're doing a presentation. Or the other thing is you're doing a report for somebody. The chief therapist comes in and talks to you as a therapist and says, I need you to tell me which patients of yours are, what their diagnosis is, and what their doses are, and which physician they're with, et cetera, et cetera, et cetera. That is a report. You need to pull all that together. You need to all your charts, and you pull it all together and you make a chart. Whether it's a pie chart or a graph or something like that, along of course with a written report. That would be our technical writing. Make sense? Okay, so let's go. Okay. So what do you write? At home, at work, or for learning? So what do you write at home? Do you write anything at home?
Chore list.
Okay, chore list. Grocery list, I was gonna say that, grocery list. What else do you write at home?
Writing notes to my children.
That's a chore list, yeah. Okay, so what do you write at work? Those of you who are actually working, not in the clinics, but if you're working outside the clinics, what are you doing at work? Nobody's working outside of the clinic? Okay, from that.
barely.
For learning, okay, so what are you
I
doing
wasn't listening.
for learning, apart from my stupid thing about trying to get a job, okay? Notes. So are you taking them by longhand and then put them into the computer? Or are you doing your notes in the computer or on your phone or whatever you're doing?
I just write them.
Or you just handwrite it, okay?
Depends.
I remember stuff when I type it out, when I handwrite it, it's to memory.
Yeah,
If it's something I need to keep, I'll put it in my phone because I'll lose it probably.
right, okay. So the other thing is that if you're writing, say your notes, you're writing notes. You normally, if you're writing notes, you normally don't use what I would count as proper English. You do abbreviations. You do your own shorthand that only you can understand, that type of thing.
Thing is, I usually don't understand it later, and I'm like, what the heck did I write?
Yeah. The other thing, when you're at the clinical site, if they allow you, once they allow you to write in the therapist's notes about Mrs. Smith having diarrhea or Mrs. Smith being nauseated, etc., etc., etc. Please don't use contractions. Normally, you would, patient complaining of. How do you write that as a contraction? C/O. C/O. As a student, you do not use those. You put Mrs. Smith complains of nausea and vomiting overnight, or nausea and vomiting over the weekend, or diarrhea plus. Whatever. So try not to use contractions as a student. Okay? So that's one thing that you would do. Another thing is, please don't use tech or text speak. if you're writing a report or even a note to a physician or one of your therapist's colleagues or whatever. Don't use text speak. Everybody knows what I mean by text speak? Okay, things that I have to
LOL.
look twice at to figure out what it is.
LOL.
Yeah, well, I know LOL.
LMFAO. Lots of love.
But, no, it's, this is another thing. I've noticed that a lot of people who email don't capitalize anything. If they're writing something and it's, I will be da 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 da, and the I is a small I, which bugs me tremendously. And I think it's from texting. I don't know, or maybe they just write that way, I don't know. But be careful of not using capitalizations. Especially if you're doing a report for somebody. Okay, what opportunities do I have to give students to write? Oh, Lord, okay.
We really don't need any. You can just ignore that.
So, business, technical writing, also known as business writing, workplace writing, professional writing, informational writing. Not about covers everything. Workplace writing, sure, you're writing notes for your colleagues, you're writing a note for the doctor. You may even write a note for the patient. If the patient doesn't remember, if there's who's done prostates? Okay.
Many.
Bladder has to be full, correct?
Yes.
What information do they give the patient to tell them how much they have to drink in order for their bladder to be full? Or do you know?
So they were saying that you can have a full bladder and not feel like you have to pee yet. It doesn't have to be 100% full because you can overfill your bladder too.
That's right.
But also people were like, oh, I drank 2 bottles of water this morning but still didn't have a full bladder.
Treated at 2:30, 2 bottles.
No, it's at they're at like 10 in the morning, and I'm assuming.
Severely dehydrated.
Yeah, well, it depends entirely on the normal size. All people have different sized bladders. Some people have bladders that are tiny and they have to go pee a lot. Other people can drink water all day and not go. Now, there's 2 things to that. The fact that people can drink all day and not go, that could be that they're just too busy to go. And the problem with that is that if you don't flush out your bladder, then you're liable to get a bladder infection. So being too busy to go shouldn't be an excuse. You should really, especially if you're drinking a lot, and everybody now drinks water as if it's going out of style, you know? I saw
My
somebody
weapon.
coming in with a gallon milk jug full with water, and I said, "Start the whole week?" "Oh, no, you drink that in a day."
Yeah, that's what you're supposed to do.
Yeah, so, you know, with that kind of thing, you really should flush your bladder. It should go pee. You don't wanna go in the, you know, so, anyway, that, apart from that. So, do you know if the patients are given written instructions as to how much they should drink to fill the bladder? Or is it, excuse me, is it a case of trial and error in the first couple of days? That's usually what it is. You drink enough so that you, if you really had to, you could go pee. But you get the overachievers who drink and drink and drink and then sit in the waiting room going, and they know they can't or they shouldn't. But, 9 times out of 10, they have to go and then we start all over again.
What if they're incontinent? Because we have one like that we did a CT scan for. It was like a pain. We're like, we need you to go to the bathroom because you refused a rectal balloon and all this stuff. And it was just like, we had to run the CT like 6 times.
Are you talking incontinent of urine or feces?
So,
Completely.
So if let's put the easy one first. If you're incontinent of urine and it's prostate, I hate to say this, but you can get something called a penile clamp, which looks like a big clothes peg, and the patient basically puts it on their penis and it stops them from urinating. And that helps those guys. It also helps the patients that have a catheter in place. They can clamp off the catheter and that stops them from emptying their bladder. If they're incontinent of feces, there's not an awful lot you can do. You can try. They can try some medications, but that usually doesn't work because it's muscle that usually is causing it. So it's the sphincter that's usually damaged. So yeah, that's difficult, especially if
they
they're.
said they're just gonna have to block off more time for him because trying to get him how they need him each day is unpredictable.
No, what I was going to say was, if you had a person who wasn't sure how much they should drink, or whether they should drink and how much they should drink and how often they should drink and you could actually write them notes saying that you can take 16 ounces of water and drink it, or 16 ounces of fluid and drink it, and then take another 16 ounces before you leave the house and drink it on your way to the apartment. And that should fill up most people's bladders. But again, it's very much trial and error. So you could write out those instructions, and that would be officially technical writing because that's what you're doing. But of course, you have to check with your physician on that. You're allowed to do that. So that would be workplace writing. What about professional writing? Where would you do that? It's also called technical writing, but professional writing. It could be lumped in with informational writing too. Professional writing and informational writing.
Like if you're writing a handbook or a manual for use of a piece of equipment or.
Yeah, you could do that. That would be more informational writing. Professional writing, if you were doing a paper for the journal, for our professional journal. There's a journal called Radiation Therapist. And there are articles from therapists in that journal. So if you wanted to, you could do that. And that's where a lot of people do that. And that is definitely professional writing and technical writing as well. Because you're giving other therapists information on a technique that you use in your department that is new and improved, or nobody else in the country does it, or there are people doing it other places, but we have this twist. That is professional writing because it's in the journal or in a journal. And then of course there's the more professional one, which is writing a book. And you really have to be technically proficient before you start writing books. Okay. What is technical writing? It's a type of everyday writing that surrounds us from the time we wake up and climb out of bed, until we climb into bed at night. So, technical writing, directions on the toothpaste tube. Believe it or not, that's technical writing. Nutrition benefits on cereal box. Business letters and catalogs that come in the mail. Written instructions for assembling a new product. Tax receipts and notices, product safety information. Now, if you can actually make sense of written instructions for assembling a new product, that has to be technical writing to be able to understand it. Would you say that those are technical writing? And why are they?
These things are up here.
Yeah. Are they technical writing?
Yes.
Yeah. Why?
They're formatted, formal, informative, and
Yeah.
universal.
They're informative, definitely.
They're not directed to anybody specific, it's a general
Okay,
audience.
it's a general information, yeah. And they're instructional, okay? Letters and catalogs. It's gone again, okay. Okay, so how is technical writing different? So the
You might have to
information is organized, presented and communicated in a specific format.
Yeah.
The writing is concise, clear, and accurate. The writing takes into account the audience's needs, biases, and prior understanding. The writing presents information to help a reader solve a problem or gain a better understanding of the situation. And the writing conveys technical, complex, or specialized information in a way that's easy for a non-technical reader to understand. Okay, so ignoring the bottom one for the moment. What in radiation therapy, if you were writing something in radiation therapy for radiation therapists, what would fit into these areas? Obviously, it has to be concise, clear, and accurate. The writing takes into account the audience's needs and biases and prior understanding. Writing presents information to help a reader solve a problem or gain a better understanding of a situation. Normally, if we are presenting something, if we are giving a lecture, then we presume that the audience has a background to understand what we're talking about. So we've been to a conference, we found a new technique which we think is going to be wonderful in our department. And you have to share it with your staff people. So you want them to to have a basic understanding of what you're talking about. They're all therapists or physicians, so they all should have a background knowledge. But you have to be able to present the new situation or the new technique in a way that they can understand it. How would you go about doing that?
How about writing the instructions?
No, how would you go about presenting the information you want to present to them? It's a new technique. They know it's a new technique for treating a breast patient. So they have the basic understanding of treating a breast, but you have to inform them of a new way of doing it. So what is the best way to do that? Pictures, diagrams, video perhaps. You get one of your cronies, you get one of your buddies, and you position them in the way that you need to do for this new technique. Most therapists are visual learners. So the more pictures you can use, the more diagrams you can use, the more video you can use, the more it'll be more acceptable to your audience. One-third of all employees in America's top companies are poorly trained in writing and cannot compose a coherent business response. Conscientious employers are retraining employees to write in the workplace. That is disgusting, to be honest. 1/3 of all employees are poorly trained in writing and cannot compose a coherent business response.
I think that's being generous.
Pardon?
I think that's being generous.
Oh,
I
yeah,
think it's way more than that. I mean, as a teacher,
yeah.
By the
And I
time I
think-
saw students in high school, what they were writing, and it's on us as teachers.
Yeah.
I mean,
We
just
weren't
in
teaching them to write.
college, like,
What?
just even in college, like,
Yeah,
when we do like discussion boards and stuff in class, like in
Oh
English classes and stuff, like, it's awful.
Yeah.
And
it's
like, did your kid write
I
this?
know nothing about grammar whatsoever.
My first class when I came here, I'm one of these people who is very
Nobody admits. I don't
Anal.
understand that.
about how something is written, how something is spelled. And my first cohort here, I asked them to do a presentation for me. And the presentations were good, and they were standing up here and doing, presentations with PowerPoints and stuff. But I asked them also to write out what they were going to tell me. And the English was a disaster. There was no punctuation, there was no capitalization. And I had told them that they were getting marks taken off for bad English. And they were mad at me because I took marks off. And I said, well, I warned you.
I mean, that's a part of professionalism.
It is.
You cannot represent yourself as a professional, sophisticated person if your grammar is atrocious.
Yeah.
It's just, I mean,
Yeah.
it's definitely gone by the wayside, but I think a lot of that is social media, the
Yeah.
acceptance on social media.
And
is
that's a lot of it. That's a lot of it.
like
yeah.
literally talk the way that they write on social media now these days. I'm like,
Or they write the way they talk.
Yeah.
They write the way they talk.
It's frustrating that, like, in classes, like, teachers don't hold people really accountable.
Accountable?
I think
Yeah.
they just,
Well, it's a
Like-
breakdown from the very bottom, I think, from from elementary on up at this
Yeah.
point.
And if the
Um,
child gets left behind.
We just, you know, first of all, we just don't have time anymore. There's so much in the curriculum that as a teacher, you're just, you know, and the problem is the very basic
Yeah.
stuff gets tossed out.
Yeah. Well, I almost failed first grade because I was okay with cursive, but there was like some stuff that I just wasn't getting, like I just wasn't able to do.
Right.
They don't teach
And
us.
she threatened to hold me
You
back.
don't teach cursive anymore?
No.
She threatened to hold me back for it.
That's so sad.
I learned it at
My
home.
kids bring stuff to me and they're like excited if they can understand it, because to them it's like a whole other language.
Yeah.
I only learned it because I learned it at home, but they did not teach it.
No.
It's not
I,
But you had to sign your name, so.
yeah,
Make it up.
this is one thing that I'll let you guys know. This was several years ago, and we were still in Canada at that point, and my husband went to do a talk on safety or something, I can't remember. But one of our friends, our very good friends, was a teacher of what they call language arts, they still call it language arts. And they were 8th graders, I guess. Yeah, they were 8th graders. When did they jump from junior high to high school?
8th to
Ninth.
9th, sometimes
Yeah.
9th to
Okay,
10th.
so they were just heading off to high school, so they were still in junior high. And so Tom had done this presentation for them, and Mary had got them as a language arts lesson to write a letter of thank you. So we were over for dinner one night, and Mary says, "Oh, here, a whole bundle of stuff for you. What's that?" "Oh, it's the kids' thank you cards for you."
Oh, glasses of wine before you drink, read through all those.
And Tom's sort of sitting there going, "What the?" And Mary says, "What's wrong?" He said, "Did you look at these things?" She said, "No, I didn't want to look at them because I wanted your opinion first before, I wanted to see your face before because it was part of their presentation. It was to begin to us, and then she was going to photocopy them and then correct them."
Yeah.
The spelling was atrocious. The grammar was even worse. And punctuation was non-existent. And these were good kids. I mean, this was the class which was the part of the dean's list supposedly of the junior high. So, but it was hilarious. Yes, and we did have a couple of glasses of wine. But we're sitting, and 4 of us are howling at these things, absolutely howling. But
I mean, they do in elementary school, they cover all the bases. I mean,
Yeah.
I'm just going through this with my kids, and they do teach it, but they don't reinforce it.
Yeah,
When you get to the higher grades,
You learn it one
continue
time
it.
and
they just
that's
want to
it.
get you through
Yeah.
and moved on. By the time you get to middle school, they're like, good enough, just go.
yeah,
Because even I feel super uncomfortable when it comes to like grammar and spelling. I'm like some of the therapists are like, "Can you type this in the notes?" And I'm thinking, okay, please let me spell this right in front of them so they don't laugh at me.
Well, they kind of have their own language
One thing
per
we're good at.
department, I think, too. And some of the abbreviations, I would have to ask them, what does this mean? What does that mean? They're like, oh, that's how Candace abbreviates this, and we all kind of do it the same way. So
Yeah.
and because they all work together, so
Yeah,
they all
and that's
understand
true.
each other's language.
Yeah, OSHA and, not OSHA, sorry, Joint Commission and JCERT are the 2 bodies that we have to deal with. Joint Commission is for the hospitals. JCERT is for the schools. And there is, I think it's Joint Commission has a list of approved abbreviations, which all departments are supposed to follow. However, as I showed you in that book, there are a lot of abbreviations that are used, usually by physicians, that are totally out of left field. I mean, they're just way out there. And you have to know them, otherwise you'll go to the doctor, can you tell me what this means? And he looks at you as if you're an idiot. You know?
For years.
Yeah, exactly. Well, every time you see this, this is what it means. Well, why can't you use this one, which is approved? Oh. So, this doesn't surprise anybody. No. I mean, we all know that there's some kids who leave high school and can't read or write. And that's sad. It doesn't, funnily enough, it doesn't astonish me, but it's sad. They actually can get through without reading and writing very well.
And they're the same ones that are like, I want to be a nurse, and I'm thinking,
Yes.
how are you
Oh, I
gonna be a
know.
nurse?
And you go to other countries and there's like a minimum requirement of learning 3 languages before
Yeah.
you even get out of like elementary and middle school.
Yeah, that's true.
Like,
My-
the-
my
the
son was,
standards here are so low.
My,
And that's why we lost, we used to have an agreement, the US used to have an agreement with Canada, UK, and most of Europe. So if you graduated from a school in the UK, you could work in the US without taking the registry. And vice versa. Now, the US has no, because unfortunately, the educational system is a low standard and nobody's going to accept it. One of my friends she trained in Canada, she worked in the Netherlands. And most of the medical textbooks or technical medical textbooks are all in English. So anyone who's a medical professional speaks English because they have to, because the textbooks are in English.
Every country I've been to,
Yeah.
there's some amount of people that speak English.
Oh,
in
yeah.
addition to 1 or 2 other languages.
Oh, yeah.
We're like the only country where they have this attitude, like, you come here, you just speak English, and I just don't.
Or you go there and you're expected to be understood when you speak English, you know. And it's a generational thing. The very old people, like my parents' generation, World War II generation, a lot of the older people in that generation speak English because of the British and the US and the Canadians all going across and speaking English. The locals spoke English back. Or the younger generation speak English because they're taught it at school. It's the middle generation that don't speak English quite as well. But most people in Europe speak English, which is really good for those people in North America who will not learn another language. But I'm getting off my soapbox now. So anyway, so basic skills. Read, writes, performs mathematical operations, listens, and speaks. That's basic skill. Thinking skills. Thinks creatively, makes decisions, solves problems, visualizes, knows how to learn, and reasons. Now, ask a question, ladies and gentlemen. In school, were you taught how to think creatively or solve problems?
Creative writing and algebra.
Okay.
Sorry, this door is really functional.
What?
The door. We were marked wrong.
Oh, this door?
Yeah, so. Open it. Sorry.
Okay, no problem. That's probably why most people leave it open.
I do. Yeah.
Sorry.
So,
I didn't do
I
that.
must admit, okay, if you do creative writing and algebra, that would solve problems and think creatively. But those people who don't do creative writing or algebra, are they taught to think? In most schools, you don't get taught to think. You get taught how to pass tests. Memorize, rote. Everyone know what I mean by rote? Rote is memorization. It's like Pavlov's dogs. If I tell you this, you remember it. And if I ask you in a week's time, what is this? You'll spit back at me exactly what I tell you. So it's rote memorization. That's no way to pass tests. Because in the registry, you have to think sometimes. A lot of it is memorization, but a lot of it is just learning how to think and learning how to solve problems. And personal qualities displays responsibility, self-esteem, sociability, self-management, integrity, and honesty. To be a radiation therapist, you need these. You need responsibility. If you screw up and you do something wrong, you need to go and say, I'm sorry, I messed up, this is what we did. Never try to hide it. It's important that you take responsibility for your actions. Self-esteem, sociability, self-management. What does that mean? Self-management?
Self-control.
Self-control, okay, self-control. What about time management? Would that be included in self-management? Yeah, okay. So time management. You've got 40 patients to do. And you've got 8 hours to do it in. You need lunch. You know that every patient takes 15 minutes. You start at 8. When will you finish? So each patient takes 15 minutes. You've got 40 patients to do. How many patients in an hour if you're doing 15 minutes per patient? 4. So 8 times 4 is? Pardon? 32. You're missing 6 patients. So you're going to be working overtime, aren't you?
Some will come in quicker than 15.
Yeah, but some go over their time.
Yeah.
It does usually balance out pretty well.
It does balance out, yeah. But that's your normal time limit that you have for a patient is 15 minutes.
I think they told me, who's at the Proton Center? Do they have 6-minute slots? They told me that at UF that there are places that have Proton Centers that are 6-minute time slots. I was like,
Yeah, but that's.
There's work 6 hours.
They'll actually.
No, protons take a lot longer,
Dave's take like what hours?
an awful lot longer.
And then,
Yeah.
I mean, the fastest.
sometimes we get done at like 2:30. Sometimes we get done at 3, 3:30.
Never,
Not
never 6.
8 to 3.
fast ones. He said like scheduled
Even if they
6-minute
keep
time
going.
slots. I was like,
They're just like,
Yeah, I don't
okay,
think
no,
so.
no.
We're only drinking 2 or 3 pills.
Just
Maybe
make
it
sure
wasn't-
I'm
I'll
not
let you
doing
into a little
something else.
secret now. The Proton Center, they're both UF, right?
Yeah.
The Proton Center in Jacksonville and the center in Gainesville don't talk a lot. When we were during COVID, when this was all starting, and I was speaking to Oh, I know what it was. When the Proton Center opened up a couple of spots, and I said to Ernie, who's the boss, or at least his chief therapist, I said, so do you know anything about what's happening with, can you tell me anything what's happening with Gainesville? And he said, they don't talk to us an awful lot about that. So they may be the same group, but they don't talk about it.
Great communication there.
No. No. But, individual people may talk, but the departments don't talk. So 6 minutes is a little, I would say that was probably not.
Maybe they meant electrons, maybe I heard it wrong.
Maybe it could be electrons, but as photons, no. No, that's a little erroneous. I'm not going to say the line, but it's erroneous. Nobody is going to do a photon patient in 6 minutes.
Plus, that makes the patient feel so rushed, like.
Yeah,
That's what I said. I said, I feel like at that point, they're just a number. They're not even
Yeah.
a person anymore.
and that's basically what you're trying to do, is make the patient feel that they are a person rather than a number. The one thing that I like about this field, I always have liked about this field, is that the patient is always a patient, is always a person. We treat the whole person. It's not like X-ray where you've got a chest coming in. You bring them in, okay, bye here, hold your breath, thank you, next one please, and it goes in and out like that. Obviously that's not
Very
all the
similar.
time, but that tends to be what it is. In radiation therapy, we tend to look at the patient as a patient. And I remember one of my students getting into trouble by one of my chief therapists that I worked for, but didn't work with her, worked for her. They said something about, Dr. Kelly's kidneys just walked in. And obviously everybody knew that it was a patient with a kidney attached, and the chief therapist basically heard this from her office,
Oh my god.
and all we heard was the name and, "You come in here now." And I thought, so the poor little student went,
That sounds
"What
poor
did
little
you just
student.
say?" Who taught you to say that? I just heard it somewhere. From whom? I don't remember. Okay, well, never do it again. So this happens, but I worked at one department who we had a little x-ray machine in the department, an x-ray room, so that if the doctor wanted to check a chest x-ray, they didn't have to go up to radiology, we could do it. We had an x-ray tech in the department that could do these. And I was working with her at one point, I can't remember why, but I was working with her. And she said, "Oh, by the way, we've got a leg coming over." And I said, "Oh, that's nice," thinking that it was probably somebody attached to the leg. It wasn't. It was just a leg, a lower leg. And so the physician brought this leg across and then amputated the leg. And they wanted to do a fluoro looking at, they were going to put some radiopaque dye into the veins, and they wanted to see how it moved through the veins. So the leg came over, it was a parcel. was a brown paper parcel. And they put it on the x-ray table and we unwrapped it. And sure enough, there was this leg with the foot attached. And it was that was a guy's leg, so it was about that size. And the dog pushed this venous, the dye in through the venous system, and we did the fluoro and we watched this going through. It was very interesting. But, you know, this is something that you shouldn't do. Say, oh, well, who's due next? Oh, it's the brain of Dr. whoever, you know. That's not good. You'll get yelled at for saying that. So, Mrs. Smith, who is, you know, we're treating the kidney, and she is Dr. so-and-so's patient. That's it. I remember calling a physician and saying, I have Mrs. Smith for you, or Mrs. I can't remember the woman's name. Who is she again? I said, she's the lady we're treating her, I think it was her right hip. So, right hip. Remind me, what was, I said, oh, she's breast, but you're treating. Oh, yeah, right. Okay, I think I know her. Right, I'll be right down. And she came down and said, oh, no, that's not Mrs. Smith, or whatever her name was. I said, well, she's a right hip, she's your patient, and she's breast. Oh, okay, I wasn't thinking of the right patient. Okay, but I'll see you right away. So, workplace competencies, resources, identifies, organizes, plans, and allocates resources. Interpersonal, works with others, acquires and uses information, understands complex interrelationships, and works with a variety of technologies. So, resources, identifies, organizes, plans, and allocates resources. So would that cover radiation therapists? Apart from probably allocate resources. It would probably cover maybe a lead therapist, right? So he or she would have to organize, they'd have to plan, and they'd have to allocate resources. So one of the therapists isn't coming in today, so somebody else is gonna have to take her place. His place. Works with others. Oh, that's a goodie. Everybody in our field works with somebody else. You do not work alone. Has anybody seen any therapist working alone, apart from in CT? How many staff members do they have on a machine?
3.
2?
Two cycling. Sometimes if they're running, sometimes they're overstaffed or they're really busy on
Still
proton.
overstaffed.
Yeah. Sometimes they're really busy on proton, they can't send an extra hand down, so the two therapists on electrical 1 or Linux 1 and 2, they'll switch between setup and they'll go and affirm things are correct.
So there's basically one therapist and the other therapist comes in and checks. Okay. Everybody else have 2 therapists?
We have 3.
Minimum? Anybody have 3?
Sometimes we have like 5 or 6. It gets very crowded.
That's because probably they have one machine down?
Yeah. Or the other machine will have like a big gap in their
Yeah.
schedule, so
Yeah.
they'll mosey on our way and discuss things, and then they help out while they're there. And
Yeah, right, yeah. Or
See,
give
when
them
you
coffee
guys
break
come
or lunch
over-
break or something like that. Sorry?
I was telling Molly, when your people come over, they just talk. They don't help out with anything.
yeah, mine chat. Mine are very social.
They come over, they just talk, and we're like, okay, and we're like walking out of the room, and they're just like still talking, like, okay,
There's a
bye.
definite divide between your group and my group, if, like personality wise,
Mhm.
for sure.
One of the therapists said that's the first thing they got onto her for when she started working there because she was too chatty.
Yeah,
She said she graduated from this program in 2020.
Who's that?
Stephanie,
Stephanie Boom.
her last name starts with a B, but I can't
Baruti?
pronounce it. Yeah,
Oh, where's she working?
Orange Park Campus.
Really? Oh,
She's so sweet, but she's like, I talk too much, so I have to like keep it short and just walk and talk.
I didn't realize Stephanie was there. Say hello to her for me, would
She
you?
said since February.
Yeah, okay, that's good. Yeah,
Now she's
Stephanie
definitely
was
gonna go
a
visit you.
She's so sweet.
Yeah, there's definitely a line in draw with patients, because some of them are very chatty, and then I forget that they're trying to align the patient.
Yeah,
And the lady's going on and on about her kittens, so her chest keeps going up and down, and
yeah,
well, they're looking at me like,
yeah. This is why we have to be very careful. You can, the idea is that you bring them from the waiting room and you talk to them all the way into the room.
Yeah.
And you say, how you feeling, anything problem, yada, 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 and you keep them walking, because some people will stand. If you ask them a question, they'll stand there and they'll talk.
Oh,
So you have to keep them moving. You know, what you do is you keep them, you walk ahead of them and you insist that they have to move, you know? And then, but once they go on the bed and we start aligning them, normally what you'll see is, now, can you just keep quiet for just a couple of minutes till we position you? Then, of course, you're going out of the room after that, so.
they walked out like 2 or 3 times while the patient is still talking to them. I'm like, I feel so bad for them. I know they're trying to keep a schedule, but they're like, okay, we're all set, and then they'll be like, so what time am I coming in tomorrow, or asking me
Well,
doctor questions and stuff,
yeah.
and they just kind of
Well,
fall over their shoulders as
the
they're going
idea
out.
behind that is that what you do in that case is that, you know, if you keep still, Mrs. Smith, because your chest is going up and down, we're trying to position you in the correct place. That's the thing. So when they hear that, they're like, okay, you have to keep still. And then they'll, you know, you go out and they'll chat as you go out and you'll say, okay, hold on to that thought, we'll be in and we'll tell you as soon as we come back in.
See, mine don't talk because they all have masks on and they're like, I want to get this over with and get my mask off. So I don't have that issue.
Lots of special requests too. Like, if you position it one way, and you're like, can we position a different way this way? Can we try this differently? So, yeah.
No.
A lot of
No.
Well, the electron people, they do, they let them.
Well,
To an
electrons
extent.
are different.
Yeah.
Yeah, electrons are different. So, we've decided that everybody works with others. Whether they work well with others is a different matter, but they work with others. Acquires and uses information. Yeah, we do that, don't we? We have all the chart stuff and everything's there, and whether it's on hard copy or electronic copy, we have the information. We use the information. If any more information comes about, we'll do that. Understands complex interrelationships. Oh, there's a good one. Well, I would take this to be the therapist and the patient, okay?
I thought you were talking about software.
No. Well, the acquired uses information is software. And you will get used to it. It may look as if it's a mountain to climb, but you will get used to it. And remember, the professionals, these guys are professionals, they make things look easy. So once you get the hang of what you're doing, they're starting with you at basics. Once they're sure that you can handle the basics, then they will go ahead and get you further into the software. So complex interrelationships. So this is, I'm going to take this as the therapist and the patient. Patients can be very complex. You ask them how they're feeling. What's the normal reaction from the patient? I'm feeling good. I'm okay. Is that always true? No, it's not. You have to take what the patient says with a grain of salt, basically. You have to inquire a little further.
I had a patient crying while telling me she was fine.
Oh, yeah.
Sounds like me.
Did you
Yeah.
get to the bottom of it, or did somebody get to the bottom of it?
Yeah, the lead therapist like took her and started talking to her and stuff. But I was taking her mask off, and she kind of looked like something was bothering her. So I was
Yeah.
like, "Are you okay?" And she nodded her head yes, and then started like bawling.
In that case, you really need to take them aside.
Yeah, that's
and
the lead
talk to them,
therapist did.
Because, you know, you're never going to get to the bottom of it in a couple of minutes.
Yeah.
You know, so what we used to do was, we'd say to them, "How are you?" "Oh, I'm fine." And then we'd say, "Look, we are not being polite. When we ask you how you're feeling, we really mean how you're feeling. We don't expect a pat answer like, 'I'm fine.' We really want to know how you're feeling." And that usually helps them. Not if they're bawling their eyes out, because that is something else entirely. But if they're had a bad night, or they were nauseated, or they had diarrhea all night, or something like that, then that's the kind of thing that will come up in that thing. "Well, you know, I had a bad night, you know. I stupidly went out for Mexican food and it went right through me," or something like that, you know. And then, okay, yeah, what did we say about Mexican food? So if you're treating the pelvis, no Mexican food. Nothing too spicy.
Spicy, greasy, dry, so. Something like that.
Yeah, something like that. So you get used to reading your patient. Non-verbal communication is 90% of what we do. We're reading the patient. And as you get used to the clinical side, you'll see that. You'll get to know it. You'll get to use it. The therapists are much better at it than you are, but that's because they've had lots of practice. So you'll gradually get used to it. You'll gradually get to know it. And, here's a good one. Works with a variety of technologies. You're using multi-million-dollar machines, ladies and gentlemen. You're using high-security software that is meant not to fail. However, it does occasionally. And how many monitors do the therapists have to watch?
Like each or total?
Yeah. Like
We have 9 total.
Enterprise in ours, like the whole wall that we have.
You have like 2 full walls of
Yeah,
freaking
yeah,
monitors.
Yeah, 3 people on, seated almost all the time.
She's so
like,
hot.
this person will be on 3 to 4 monitors. This person will have around 2.
Yeah.
And this one is on 2, sometimes 3. So.
Yeah.
But usually someone's scheduling and reviewing
Yeah.
charts.
Right, yeah.
And then this person is like the verifying person who's checking
Mhm.
images and that kind of stuff. And then this person is the one that's.
So let me
Beyond
put it
beyond.
this way. For the treatment itself, how many monitors?
3.
3. Yeah. So you have, and then you have the cameras as well. So your job at this point in time should be to obviously watch what they're doing on the monitor, on the monitors, but also, or the computers, but also keep an eye on the patient through the monitors. So how many people have monitors above the closed circuit TV monitors above there? How many are countersunk? What I mean by countersunk?
Ours are above.
Ours are above.
Okay, yeah, I remember that from, unless they've changed it drastically in Orange Park, yeah. I went in there,
I would prefer it up. I don't think I would like it under.
why do they have to be, why should they be under them?
Privacy.
Exactly.
What would that?
Because if your monitors are above here, everybody walking past can see your patient. They should not
Ours
be
is set up
allowed to do
related
that.
then, because ours is to go in the room and come around to see our.
Yeah, all we have is a curtain.
No, I'm not talking about the computer monitors, I'm talking about the cameras.
The camera monitors,
The camera monitors.
they're all in our room. We have like specific control rooms.
Yeah, I know you have,
Yeah,
I know
our
you have.
monitors are right above the regular computers up on.
But anybody who walks into the control room
Yeah.
can see the patient, right?
Uh-huh.
Yes. That's why most new centers are countersinking their monitors. So they're basically in the counter.
Mhm.
So that only those people who are working with the patient can actually see the patient.
So if another therapist working on another machine comes over, they're not supposed to be able technically to see those cameras?
Exactly.
They don't
So
really have
if they're coming over to send you to lunch or something like that, obviously they're over there. But if they come over to ask a question, they should not officially, by HIPAA, be allowed to see the patient.
Isn't there like a general, all the therapists here
No.
technically
Technically,
take
no.
care of them?
By HIPAA, you should only be aware of the patient whom you are treating. Does that make sense? So if you have 2 rooms or 5 rooms or 6 rooms, doesn't really matter. You should officially, and I'm saying officially, by HIPAA, you should not know any of the patients. You should not know any of the patient's medical records or how they're being treated or why they're being treated, except for the ones that you're physically treating.
Technically, we broke the rules, bringing you over to our side to show you icons.
Yeah, but I'm a student, okay?
That is an educational thing, yeah, but.
And we ask permission
This
first.
is why I'm saying officially.
Right.
Now, in a small department, perhaps you have 2 rooms. And you have 1 room here and 1 room here. And you may be divided by a screen or something, but you're close enough to yell at somebody or talk to somebody, right? So you see patients going in and out in the other room. So you basically know them to say hello to and what have you. But you should not know what they're being treated for or their medical history or anything like that. By HIPAA.
People need to come in and see what reality looks like.
HIPAA no reality, that's why they make these stupid rules.
Their rules are.
But I'll tell you a story. We had, when HIPAA came out at first, a lot of states didn't take up HIPAA immediately it came out. And when HIPAA hit Texas, I was in El Paso. And that was 2002. I was in El Paso. And HIPAA started. And we were not allowed to go out into the waiting room and call our patients. Normally, we would go out into the waiting room and say, Mrs. Martinez, would you come back, please? And Mrs. Martinez would stand up and walk back with us. We were not allowed to do that when HIPAA came in. It eased off a little bit after that, but what we had to do was look at the photograph of the patient and go up to the patient themselves and sort of very quietly say, Mrs. Martinez, yes, would you come into the room?
It's like playing real life Guess Who. What if they dyed their hair, cut their hair, or lost their hair? So
Or
it's
lost a lot of
Yeah,
weight.
yeah.
Like some patients
Yeah,
look completely
exactly.
They're
different.
going around quietly going, are you Miss Mark? Sorry.
Well,
Are
the
you
problem
mixed
with, the problem in that case, I hate to say it, but the problem was that we probably had 6 Mrs. Martinez's sitting in the
Right.
waiting room.
Yeah.
So we had to have, you know how we say something like, what's the 2 pieces of identification that you use? Their full name and their birth date, right? What happens if you have 3 Mrs., this happened to us, 3 Mrs. Martinez's, all with the same first, middle, and last names? And 2 of them had the same date of birth.
So you would do what they're being treated for?
Both of them were being treated the same way.
Okay,
We were
last
both
one.
services, yeah.
Let me see your license,
Well,
your
no,
registration.
What we actually did was
The
that
same
we
person?
wrote down, Mrs. Martinez wrote, what we would say would be that we would go out and we would say we knew them. Obviously, we knew them by the time we were doing this, but this is the first date. We would ask them for their social. Because there was no other way to do it.
Crazy.
So that, and it calmed down after that. You know, for the first couple of months, it was absolutely hell. So after a couple of months, we all went to the administrator and said, this is stupid. We can't do this. It was wasting more time getting our patients in than it was to treat them, so.
So technically, you're allowed to call them by their last names, right? So that's what we do, we walk out
Yeah.
and just say their last name, and they know the drill.
Yeah, oh yeah.
I've done
And the
that.
thing about it is, the stupid thing about it is that they all talk to each other. And they all give each other phone numbers.
Yeah.
You know, call me if you have a problem or yada, 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 yada. So they all know each other. And
Half
they
of them
sit
stay at the
and
same hotel.
compare,
A lot of the
side effects and
appointment
stuff.
times.
Yeah, exactly. I mean, we had in Canada where I worked, we had what they call a hostel unit. It was for people who lived far away, like 2 hours away. And they came in and we put them up in the hostel unit, which was a part of the nurse's residency. And we had a float poker game going on there. So the guys would all play poker. And then if one finished his treatment, he'd go home and then somebody else new would come in and say, you play poker? Yeah, there's a game on, you know, it's an ongoing poker game.
That's great.
And they go for lunch together and they go for supper over to the hospital together, and we call them because they were there. We could get them basically any time of day we wanted. We were working late. We were doing 10-hour shifts or something. And we'd call them over at 8 o'clock at night, and we'd call somebody over. They all have phones in their little 1-bedroom apartments. And we'd call somebody over and we'd have 3 guys come over. Well, I'm just having lunch with them, so I thought I may as well bring them over. So you'd call for one guy and you'd have 3 of them or 4 of them on the phone. So, anyway, works with a variety of technologies, so we do that. Processing basic writing skills means that students need to communicate thoughts, ideas, information, and messages in writing, and create documents such as letters, directions, manuals, reports, graphs, and flowcharts. So if you were going to produce a paper that told somebody how to treat a certain type of treatment. How would you do it? Would you use directions? Would you use flow charts? Would you use photographs? Or all of the above? Everybody know what I mean by flow charts, right? Yes? Yes? No? And did not know what flow charts are? Okay, good. So, if I was to ask you how a prostate was treated, how would you present that to me? You can all do it as a group, you don't have to stand there.
That's all you do. That's prostate treatment.
How would you tell me how a prostate was treated?
They lay down, put a towel over them, they put on their pants.
No.
That's how it is.
So the patient comes into the department and he's going to have a prostate treated. What do you do first? What does he do first? Or what do you ask him to do? Yeah, okay. Is there anything he needs to do before you get him in the room?
Make sure he has full blood.
Okay. Anything else?
Identifies the correct patient.
Well, yeah, we've got that one. We've actually did
Pay
the
attention.
From
use
the
of
moment
the
he walks
name
in,
and
or
the
the
ID.
treatment.
So
She asks that he treat the patient.
we've got him so that he has a full bladder. What else? What does he have to do? You gonna get him changed?
Empty rectum.
Okay. So you get him changed. He still has his shoes on.
Take the shoes off.
He takes him off in the room.
Take his shoes off. Okay? Then what?
I'll have them set up on the treatment bed.
With what? Just him on the treatment bed.
Either a back lock and an
So he's walking in the room. You will have found his immobilization device, whatever it has to be. You have that on the bed. You have something for his head. You have something for his hands.
a blue ring.
They
So-
sit on their chest.
You get him on the bed.
They put on their chest. They just
You put his feet or his legs in the back lock. You have his head down. You have his hands on the pillow, on the ring on his chest. Now what?
We do the,
Now comes the
Prostate.
towel. Why? Why do you need to put a towel over them?
modesty,
Pardon?
modesty.
Okay. So you need to pull up his gown or pull down his pants or whatever, depending on whether he's left his underwear on or not. Should his underwear be on? Or does it matter?
Oh,
Off.
Off. Okay. So he has nothing on and his back's blowing in the wind there. Okay? So you have him lying there. His hands are on here. You put a towel over the top of him, then what? What do you do next?
Prostate blood.
Pardon?
Prostate blood.
We do
Okay.
that before the bath wall.
Yeah.
Okay, so this is why you have to think ahead, okay? So if you're using a prostate balloon, not everybody uses one. So that's a rectal balloon, right? So if you're using a rectal balloon, obviously that goes in next. So how do you put the rectal balloon in?
The patient turn on their side and put whichever leg is not touching the back up on its side.
Okay.
That's not
Have
how
them lie still.
So the rectal balloon goes in, okay, we'll skip to the rectal balloon is in, they roll him back, make sure he's the back lock, then what?
Place the towel back over and make
Right.
sure it was comfortable, and then we start to raise the bed and does the treatment.
So you're raising the bed,
Turn on,
that's all you're doing?
and turn on the lasers.
Okay,
I've never done this before, so I'm not sure. It should be like 10.
so you're only raising the bed, you're not moving the bed anywhere else?
Move the bed in.
Okay, so you're moving the bed to match the lasers to the marks, okay? So this is, what you have to remember is you have to think in what chronological order, what you're going to do
I
next.
know. Always goes
What
wrong.
does a rectal balloon look like? I don't know if you've done one.
It's a little,
They're like
it's
really small.
it's basically a giant. Where those, when you put a needle on, but the giant, when you fill with air, in the, yeah, it's a giant syringe with a, I don't know if it's really
We
thin, but
put
a rubber
air
tube.
in the rectum, but I don't think I've seen an actual balloon. So we had a
Most of-
syringe and a tubing.
Yeah,
We would insert the
I don't know
tube
if I can do
all
this
the
for
way
a
up
foot balloon in
Yeah.
someone's ass.
pretty far.
That's what I'm
And then
thinking.
it
I'm like,
injects
wait a
air,
second.
and then
I've never
leave
done
the
that.
tube in.
that's
either.
the balloon.
You don't?
That's
I'm gonna work
an
where
actual-
you're at.
Flat. No, it's
I'm gonna go.
Yeah.
where
I'm gonna get a
Morgan
job
is.
where you don't put balloons in people's
Yeah.
assholes.
Yeah, I don't want that.
It's like, it's
Oh,
like
okay.
a catheter,
bladder.
a Foley catheter.
when we did
You know the Foley catheters that are
Yeah, yeah.
very slim,
Right.
and you put
Stick
them
a shit
into
up
the
people's ass.
urethra, and there's a
I've
balloon
never
at the bottom, or the top
had to do that.
actually,
Nerves.
and it
Treat
fills
like 10
up.
prostates a
Or
day,
you
and I've
fill it
never had
up.
to do that.
So the balloon is in that tube? I just haven't looked at
No,
it.
it's part, it is the tube.
Like having to do
It
that
just looks like one
down
solid
for like
piece.
pelvic.
We've done it like 3
You have to
times,
do
and then we have
consent
one that
form.
has a permanent,
Oh, yeah.
I can
semi-permanent
put the balloons on the
implant, space ore.
Yeah,
Do you have to do one every time or just the one?
right.
Just the one.
So, we've
First treatment,
got
and
as
then
far
just
as, getting the lasers to match the, what? No, the marks. Getting the lasers to match the marks. Then what?
We have to align the lasers to
Well, that's what I'm,
our mold first, and
what
then
mold?
the
what
back
mold?
lock, they call it
Not,
mold.
not all
Not
of them.
necessarily.
Not all of them.
It depends on how they make the back lock. Some places will mark the back lock and that marks the patient. But some people have the back locks further down, so the marks are put on the skin.
Yeah, ours are. Like all.
So what I'm saying is that you match the lasers to the marks. Doesn't matter whether the marks are on the mold or the marks are on the patient. Right?
I thought it did matter because the molds are what we're using for indexing.
Back locks,
Back
not
locks.
molds.
They call them stuff.
Yeah, we
that's
call 'em
fine.
Back
molds.
locks. Okay, so, sorry,
Jesus.
you were saying, to use the molds for what?
For indexing, because
Yeah.
in order for the patient to
That's
be
right.
And
lined
then
up.
she
Yeah.
went and called it a
Yeah,
mold.
it doesn't
Some
really
people don't
matter.
use the backlog, they just do it on the patient's skin.
Yeah,
Yeah.
everybody uses the back locks, it just depends on where the marks are put.
I think the reason ours do it both, I mean, I know that some people don't do the lines on the back locks at all.
Yeah,
But they were stressing to me that they wanted to make it more accurate to know that their bodies were placed in the back lock properly, because sometimes
Yeah.
it can be shifted out of.
right,
So even when they're lined up with the lasers on the tattoos, sometimes the internal structures can still be
exactly.
wonky.
So if you're using the back locks as a first point, you'd set them up to there, and then they would set them up to the marks on the
Then we start
patient as
touching
well.
the patients, yeah, to the back blocks and the laser. So the laser touches the back block and the tattoos on both sides and anterior.
So, to cut a long story short, you set up the lasers to the marks. It doesn't really matter where the marks are, right? I'm talking about marks, it could be anything. Some patients don't have tattoos, they only have marks. It depends on the individual departments. So if you're looking for a tattoo in a department that doesn't do tattoos, then you're sunk, right? So, and marks can include tattoos.
Yeah, we don't.
It doesn't really matter.
You guys don't tattoo?
We.
They're only the ones that come, like, they have their CTs done at a hospital, they come with tattoos, but if we do the CT at our facility, they do Sharpie marks with stickers.
Yeah, we do sharp marks.
Yeah.
with
I have
marks.
yet to see any without tattoos.
Well, that's your different
Location.
locations.
Yeah.
So your next location, you may only see patients with marks and no tattoos. It's a very much an individual doctor thing. Okay, so the marks on the patient, whether the tattoos or marks, are set up with the lasers. Okay, what do we do then?
At least for majority of our classifications, we line it up with the CT marks, CT sim marks, and then we move it to the treatment plan marks, which are green.
Okay, yeah, that's a UF proton thing, the different color marks, so we'll just ignore those for the moment. Because the UF proton center has different colors of marks for different things. So, okay, we've done all the marks.
No more marks.
We've done all the marks. We've got the lasers on whatever marks we need to treat. Then what?
We typically do a CBCT.
You exit the room.
IGRT,
Turn on the
Okay.
music.
not CBCT, because
Turn it up.
CBCT may not be available in other departments, so IGRT. Okay, so you're gonna set up for IGRT. You go out the room, then what?
They do the scan and then they check the alignment of the original CT, the original images with the current one.
And how do you do that?
I don't know.
Superimpose.
You superimpose one on the other.
But understanding the alignment, I'm not there yet.
Well, no, you shouldn't be. You shouldn't be. So you superimpose the original, or excuse me, the treatment one onto the original. So the original comes from CT.
Two different kinds, so in one window, they'll have, the obvious purple over green. But then they'll flick to another tablet and they have the black and white where they're sliding the cursor.
Yeah.
Do they do that at yours?
Mhm.
You're like sliding it back and forth
Yeah,
and you can see the differences?
It depends on the individual therapists, or it depends on how they were taught to do it. Some people, they'll do the color wash one, which is the red and green one.
Mine do both.
Some people will do the, have you seen the checkerboard thing?
Yeah.
Some people will use the checkerboard.
So they do the same goal, they have the same goal in mind?
Exactly,
Okay.
exactly. It's just a different way of doing it.
Like
Some
they do
people
that.
like the color wash, some people like the checkerboard, some people like other ways. So they can split it in 4, or they can split it in 2. Has anybody seen them use the automatic match yet?
Yeah, that's mine do that.
So they do the automatic match and then do the manual as well. So they do the automatic match to start, and then they'll fine tune it with the manual.
So it
Yeah.
automatically matches it?
Yeah.
Well, it seems like
As
they
long
don't
as
want to
it's
use
close,
that.
'cause if it's
Well,
Well, it
no,
does
the
that.
problem is that it doesn't always work.
Yeah, it has to be within like
what
3
a lot of people do is they
degrees.
start off with an automatic match to get them in the right area and then use the manual match.
I've never heard
To
of
complete
automatic.
And then
Some people
they
don't
can
like it
automatically
because they
move.
say it's a waste of time. But some people like to start off with the automatic match and go with the manual match as well. So it's a 6 of one, half dozen the other thing. So some people don't like doing it, other people do, so. So you've got your cone beam CT or your IGRT done. And everything is good. You've hit the buttons and the bed has moved. Hopefully you've told the patient that the bed's gonna move. Otherwise,
Nope,
they'll
they just do
They
it.
just do it. I was so shocked because that's what I
I'm a
figured, you know, you're
first
gonna let the
time.
patient know everything
First
is gonna
treatment,
happen
they'll
before it
lay it
happens.
on
Yeah,
my back.
normally
After
they'll
that,
do
it's
it,
just like,
normally
it's quicker
they'll
than the
tell
first
people
time.
on the first couple of days.
Yeah.
And then they'll go
Yeah,
and
I
just do
definitely
it.
pick up on that on some of the
Yeah,
other
it's
ones.
so
Yeah.
routine for them. Some of
They're
those
not
people.
as
But normally, I would
informative,
tell the
I
patient, you
guess,
remember
on
that
the
the bed,
first.
on your way out, just keep still and remember the bed will move, so don't worry about it.
Just don't move your toe.
Yeah, and that, for the first couple of days, you have to watch them just to make sure. After that, it gets to the
We line
routine.
somebody
So
up.
you've done
Or
your
you're
cone
trying to
beam
line
CT
somebody up
or
and
your,
pull
um,
I'm like,
your
yeah.
IGRT,
Yeah, we don't have that
then
issue
watch.
because we're just head and neck.
And
So
you
it doesn't
moved
really
your
matter.
patient.
If
Or
they
you
move,
moved your bed,
like if they move their hands, it's fine.
Everything's lined up correct.
There's like a whole list of fields that pop up on per patient. Yeah, the
Right.
parameters on the
Yeah.
computer, and as far as I can tell
I've
from my
done
questions, it sounds like
shoulders
they
and a
choose
leg.
which ones to do based on, if we do it this way, the gantry is gonna stop over here, and
Yeah.
then we can start here for the next parameter, then it'll go over here, so
Yeah.
it seems like they just.
So they're
they choose-
doing 3 arcs maybe?
Right, like a lot of the breasts are the, you know, the tangents and tangentials, and then there'll be 2 arcs clockwise,
Yeah,
counterclockwise.
And that's usually, they usually do that, the symmetrist usually will tell them which one they should be doing first. But you can change it.
They
But-
like trick the machine sometimes. Like before they leave the room, they'll move the gantry the way they like
Yeah.
want it.
Yeah,
And
and
it
then
like tricks the system to, it
Yeah.
just goes that way.
yeah. So that's, yeah. So you see, if I asked you how you go about, now prostate is an easy one. So if you had to explain to somebody how you would treat a prostate, that's what you'd have to do. You don't presume anything. You don't presume that the person asking knows what you're talking about. Get my drift? Okay, so. Okay. Schools need to train students to communicate essential information effectively via email. Write proposals to obtain new business, communicate key instructions to colleagues, or convey policies to customers. Who are our customers?
Nice.
Anybody else?
Their family,
Pardon?
their family, whoever.
Their families, yeah, patients and their families. Who else are our customers? If we are part of the hospital, then the rest of the hospital are our customers, because they're sending patients to us, right? If we are a standalone center, then the referring physicians are our customers. So it's not only the patients, although without patients we'd have nothing to do, we'd be out of a job. But as you guys probably will see, we won't be out of a job fairly soon. There's lots of patients coming in. How many patients are on a machine? You know, per day.
Ours is between 30 and 40.
Wow.
That's it.
We don't have as many. We have probably like 25, 30.
Okay,
Because I think we're picking up, our machine has higher energies and everything, so
Yeah.
it picks up 5 is down and 6 is down.
So how many in Orange Park?
Well, they said that they just had like a lot of patients in treatment last week, so this week was kind of low, but we had 18.
That's not bad.
Oh,
It's not
wow.
bad. It's enough to keep you busy for a little while. That's a good morning's work.
I mean, but we're getting 5 new ones
Yeah.
this week, so
Yeah.
it's like,
So it'll go in, yeah.
yeah.
So what about Flagler?
I think it was like 25. Well, we lost a few.
Mm-hmm.
And this last week was like 25, 30 patients a day.
Yeah,
And then they just approved 5 more plans.
so it's steady, right?
Yeah.
It really is steady. And depending on what kind of technology you have, it can be busy. If you have basic technology, then you may, 20
This PR
patients may be a lot.
Like a nurse.
In a department where, God forbid, you still have to run
My friend just
films,
picked up a here and
18 or 20 patients is a lot of patients.
Are there any locations that you know of that are still running films?
I think it's more
Is that here?
admin.
There was one, but they closed it down. That was the other one in St. Augustine. I'm not sure of anybody that I'm aware of that's still running films. But you could go to a department, you see that is in the process of using an old machine
Should be
while
like
they're
a
getting a new one
floating-
installed. So, you can easily get that. So, let me see what else here. Okay, what are the specific deficiencies in the public education system? Okay, so, preparing students for the workplace, top 3 responses. So reading and comprehension, 38%. Math and science. So this has been math and science or vice versa. 51 and 42, that's atrocious. Basic unemployment skills, basic employment skills.
So almost everything's gotten worse over a period of 4
Well,
years.
2001 is the orange or yellow-ish. 2005 is the orange. So the only thing that's actually got better is the math and science.
Oh, I thought this was what they were deficient in.
Well, it could be,
Like,
it could be, that's what it is, yeah.
279 right now,
So
you can do a 200
51%
rotation, where are you gonna be at?
5%.
And I'm like, yeah.
So Brown must train is a business necessity. Yeah.
Fucking Brown.
Raise basic skills to entry-level workers. Keep workers skills current with new technology. Attract new workers, required by state and local government, and provision in labor contract. Employability skills. Let's see. This is scary. English language fluency. What type of skills will employees need more of over the next 3 years? And at the bottom is English language fluency. And we're not talking English as a second language here, guys. We're talking English as a first language.
How do you know that?
So if you can communicate in English, you can either in writing or in speaking, then you're really up the creek. And I hate to think of how many students are leaving high school that have that problem. Technical writing is a natural partner to academic writing. It is descriptive, creative, and explorative. explosivity. But
That's not
the
either.
format is different and the standards are higher. Technical writing requires 100% accuracy. So if you're writing a paper or a manual on how to do something, you have to be accurate, 100% accurate. And you don't skip steps. So when I asked you guys to tell me how to do a prostate, first thing was get the patient on the bed. No, that's not accurate. If you were writing a manual on how to treat a prostate, that's not what you would start with. So academic writing, descriptive writing, technical writing, job description, incident report, resume, and process explanation. That's what we just did, process explanation. Narrative writing, observation report, progress report. So observation report would be how the patient's feeling today. You put that in your radiation therapist notes. Analysis, performance evaluation, or feasibility report. Chief therapist comes to you as the lead therapist and says, do you think we can take 5 more patients on your machine next week? And you say, no, not a thing. Well, give me a feasibility report. Tell me why you can't do 5 more patients. So we have to do that. Cause and effect, analytical report, product field test report. You've got a new brand of backlogs. And your chief therapist says, okay, you're going to use these for a couple of weeks and then tell me how they're doing. You want a written report on how they're working. Compare and contrast. Again, this could be the same thing. You've got 10 patients with the old backlogs, 10 patients with the new backlogs. How do they compare? Are they just as good? One set better than the other? Product comparison, feasibility report. And persuasive writing. Proposal or action plan. We want another machine. You have to write a report to the finance people, the CFO, which is the Chief Financial Officer, telling her or him why you need a new machine or another machine. So you have to go through and tell people how to do that. Your guys are not going to do that, not for another 10 years or so. So you've actually been working for a while. So action plans, advertisements, agenda, audit report, book review, procedure, budget, business letter, business plan, catalog, contract, critique, itinerary, all of these, and I will be sending these to you. So, or technical writing. Good Lord. Okay. Don't really need to do this. Okay, so questions on that? Otherwise, we'll let you go.